Hi everyone! The Tea and Toast Club has dropped another episode. This is a mini-series hosted by The Generalist, where we discuss all things geriatrics. If you're interested in hosting, please connect with us. We'd love to have you join the conversation about older adults. I'm Dr. Christine Miller, a Care of the Elderly resident at UBC with Dr. Dunnigan here.
Our topic today is BPSD, or Behavioural and Psychological Symptoms of Dementia. You may have heard to it referred as NPS, Neuropsychiatric Symptoms.
Let's start with a case. Picture this. The year is 1901 and a patient is admitted under yourself, the attending psychiatrist at the Municipal Asylum for Lunatics and Epileptics in Frankfurt, Germany. A 51-year-old female believes her husband is having an affair with a neighbor. As time goes on, other symptoms develop, including progressive confusion, difficulties performing IADLs, language problem, agnosia, generalized paranoia, sleep dysregulation, auditory hallucinations, and aggression. She eventually dies in 1905, likely from sepsis. Afterwards, a colleague informs you of her death and arrangements are made for you to autopsy her brain. You find histologic changes that you describe as neurofibrillary plaques and tangos. Your findings, in combination with the constellation of symptoms, lead to the naming of a new disease, Alzheimer's disease. You are Aloysius Alzheimer, and your patient is August Dieter. This is the first documented case of Alzheimer's disease and BPSD.
Pearl 1. BPSD has been around for a really long time. What actually is it?
The term just means symptoms of disturbed perception, thought content, mood, or behavior that frequently occur in individuals with dementia. BPSD is seen in all types of dementia, and over 90% of individuals with dementia will experience it. Symptoms vary by dementia subtype, with apathy being the most common symptom experienced in Alzheimer's disease, and often one which is tough to treat, depression in vascular dementia, anxiety in dementia with Lewy body, and agitation or aggression in frontotemporal dementia. Because BPSD symptoms are so varied, try to identify the most predominant symptom cluster. So, if delusions and hallucinations are the most common problem, that would be a psychosis cluster. Mood symptoms are an affective cluster, while symptoms such as agitation, aggression, and inappropriate sexual behaviors, or ISB as it's called, are considered a hyperactivity cluster. On a side note, if you primarily have behavioral symptoms without cognitive impairment, include behavioral variant FTD or frontal variant AD on your differential.
Okay, let's talk about agitation for a minute. It's quite common, with up to half of all Alzheimer's disease patients experiencing it, and significantly higher levels, around 80%, seen in long-term care patients. Agitation also increases with dementia severity, while other BPSD symptoms may not. The term agitation is really a catch-all phrase that means different things to different patients, caregivers, and staff. I think it's important that when healthcare professionals talk about agitation, we're all on the same page. There's a good consensus definition out there from the International Psychogeriatric Association. The patient must meet criteria for cognitive impairment and demonstrate at least one persistent behavior for 2 weeks or more that causes emotional distress and is a change from their usual behavior. They classify agitation as an excessive motor activity, pacing, gesturing, restlessness, verbal aggression, or physical aggression. The behaviors must be severe enough to impair relationships or interfere with ADLs. One of the major risk factors for agitation onset is boredom. This really shows the importance of managing BPSD with non-pharmacologic approaches.
One symptom which can be really embarrassing for caregivers to manage is ISB, also referred to as hypersexuality in the literature. ISB can be classified into 3 categories: sex talk inconsistent with the patient's pre-morbid personality, sexual acts, and implied acts such as requesting unnecessary genital care. ISB is more common in men than women, and frequency of behavior differs by gender, with men being more prone to demonstrate physical acts and women more likely to use inappropriate language. It's also more common in severe dementia and in long-term care patients versus patients who live at home, although this simply may be due to staff reporting. Pearl 2. What's the best way to assess BPSD symptoms?
The gold standard is the NPI, or the Neuropsychiatric Inventory Scale. There is an original version which is quite comprehensive. It assesses 12 symptoms, their frequency, severity, and amount of caregiver distress. This is the scale used most often in research. The NPI questionnaire is a modified version and completed by a caregiver in a shorter amount of time. The Australian Dementia Centre for Research Collaboration has a great website showcasing various validated BPSD rating scales. Of note, they also include cognitive tools, dementia severity scales, function measures, delirium scales, and quality of life scales. Check it out under helpful resources and links.
If you're looking for rating scales for individual behaviors, listen up. While general depression scales can be used, such as the Geriatric Depression Scale, the Cornell Scale for Depression Dementia is actually recommended over the GDS, as it was designed for comorbid dementia and mood symptoms. For other mood symptoms, consider the Apathy Evaluation Scale or Rating Anxiety and Dementia Scale. For agitation, I like the Pittsburgh Agitation Scale. It groups symptoms into 4 clusters: aberrant vocalizations, think repetitive requests, complaints, nonverbal vocalizations, motor agitation, pacing, wandering, banging on chairs, for example, aggressiveness, either verbal or physical, and resisting care for ADLs or medications. If the agitation scale points towards aggression, there's actually a scale called the RAGE scale, which helps identify the type of aggression the patient is demonstrating. Ultimately, if you're looking for a day-to-day scale which staff can use to easily chart behaviors, your go-to is the DOS, Dementia Observational System.
Pearl 3. Now I've identified that my patient has BPSD. How do I move forward?
One of the most important things you need to do is understand the root cause of the behavior. Is the patient hungry? Do they need a bathroom? Is something medical going on? There are a few different structured approaches which help with this. For example, PIECES, P-I-E-C-E-S, is Canadian. It was developed about 20 years ago to look at common precipitating triggers. It starts off with P for physical. Often this is the patient's unmet needs. They recommend using the 5 Ds to assess this component: delirium, disease, drugs, discomfort, disability. I personally like to use the 4 Bs: bowels, bladder, beverage, so when did the patient last eat or drink, and bottom, a top-to-bottom review for any possible triggers. The I stands for intellectual. What is the person's baseline cognition like? The E is for emotional. Is there a history of depression, anxiety, other new stressors? They also include trauma and substance use under E. The C refers to capabilities. This is the patient's strengths. The next E is for environment. Is the patient over or understimulated? The S is for social. It's a look at who this person is, their support networks, culture, and life history. This framework is usually completed by the whole team, preferably at different times of day, so you can get different staff and caregiver perspectives.
Next up is another acronym, DICE, D-I-C-E. It stands for Describe, Investigate, Create, and Evaluate. It moves beyond pieces to include in the development and implementation of a care plan. In Describe and Investigate, a who, what, where, why, when approach is recommended to develop an in-depth understanding of the behavior and why it is happening. Create refers to creating a collaborative treatment plan and then implementing it. 6 main strategies are recommended: providing caregiver education and support, improving communication, creating meaningful activities, simplifying tasks, ensuring a safe environment, and changing environmental stimulation. Evaluate is where you see if your treatment plan worked. Are the behaviors less frequent and severe? Has caregiver distress changed? The nice thing about the DICE mnemonic is that it also makes room for medication. As you're describing and investigating the behavior, medications are recommended if there is a safety risk. While in Create, consider pharmacologic management if there is a history of depression, psychosis, or aggression.
Some guidance around choosing which non-pharmacological options to implement. Different meta-analyses have found the most evidence for team-based care, person-centered care, caregiver education support, massage therapy, music therapy, pet therapy, outdoor activities, and exercise. In 2019, an international Delphi consensus on BPSD management ranked non-pharm treatments as DICE number 1, music therapy number 2, and caregiver education number 3. I think this goes to show the importance of bringing the family and care team together, along with understanding what's driving the behavior. Pearl 4. Let's talk about medications.
Remember, what you're doing with medications is simply covering up the behavior. That symptoms still exist, it's just not as obvious. So go back and use your non-pharmacologic strategies to find out what's precipitating the problem. Think about medications for other things like pain, constipation, or antibiotics if that's within the patient's goals of care. We know that adding on something like scheduled Tylenol can be very effective for behaviors, as dementia patients aren't typically able to ask for PRN medications themselves. I like to divide up behaviors into urgent or non-urgent. Then think about route. Do they need IM? Or would PO suffice? And side effects like sedation, falls, and QT prolongation.
There's a couple of algorithms which go through drug selection based on situational urgency. One algorithm is written by a group of Harvard psychiatrists. Another is out of Toronto, although the order in which they present their drugs is now outdated. The Harvard docs recommend IM olanzapine or Haldol only for emergent behaviors. If the situation is urgent, they recommend aripiprazole, then risperidone, then prazosin, then consideration of ECT. For non-urgent, they start with non-pharm things like decreasing anticholinergic load and optimizing pain and sleep. If sleep is a concern, they recommend using trazodone. If the patient is not already on a cognitive enhancer, they recommend starting one. Then SSRIs, second-generation antipsychotics, again aripiprazole, then risperidone, then prazosin, then carbamazepine.
If agitation is the only behavior of concern, the International Psychogeriatric Association recommends citalopram for mild to moderate symptoms. If the agitation is severe or there is a danger of harm, go with antipsychotics first. This may need to be given IM. Then carbamazepine or gabapentin. Then you might consider prazosin, dextromethorphan, quinidine, or nabilone. They also include advice for nocturnal agitation, such as sundowning. Trazodone is recommended in this case. Then, some of the newer sleep agents, like dual orexin receptor antagonists. We've heard trazodone mentioned a few times now. How does this help in BPSD?
Basically, what it does is promote sedation in patients with dementia, which reduces irritability and agitation. Recommended doses are 12.5 to 25 milligrams at bedtime. It's at least as effective as Haldol for agitation and better for mood symptoms. It also has a better side effect profile than antipsychotics. It's a good one to use if the patient is over-sedated from something like quetiapine. You can do a cross-taper between the two and end up with good agitation control but less sedation. Pro tip: decreasing quetiapine dose will also improve rigidity and mobility in a patient with Lewy body dementia if quetiapine was the rigidity culprit to begin with.
And how about using cognitive enhancers?
For patients with BPSD and mild to moderate dementia, acetylcholinesterase inhibitors are recommended for two reasons: improved cognition and BPSD symptom control. Benefits are not typically seen until 3 to 6 months of being on the medication. There is evidence from the last couple of years showing that combination therapy with both an acetylcholinesterase inhibitor and memantine is more effective for cognition, function, and BPSD than either drug alone. When looking at specific symptoms, cholinesterase inhibitors are more effective for apathy, depression, and anxiety, while memantine has been shown to improve agitation, aggressions, and delusions. In terms of when to discontinue cognitive enhancers, the recommendation is to continue for as long as there is BPSD symptomatic benefit, even if evidence of cognitive or functional decline. Only stop if it seems to be exacerbating BPSD symptoms like an FTD, where introducing cognitive enhancers actually causes BPSD symptoms.
What if I like going old school and breaking out the SSRIs? Which one should I order?
For SSRIs, citalopram or escitalopram have the strongest evidence, then sertraline. Sertraline has the least amount of QTc prolongation. Given that SSRIs take time to work, you may need to use something like quetiapine to help control behaviors until the SSRI takes effect. The other time you want to reach for SSRIs is in the case of inappropriate sexual behavior as its first line for this. There's a great article included in the references which goes through a detailed pharmacologic approach to ISB.
Pearl 5. Moving on to antipsychotics. Yes or no?
We know antipsychotic use in dementia is fairly high, around 30%. Interestingly, it's not antipsychotic use that predicts time to nursing home placement and death, but rather the BPSD symptoms themselves. Only about 20% of patients on antipsychotics will have any benefit. They don't help with anxiety during personal care, calling out behaviors, or wandering. Midazolam is a good option to consider for resistance to care. Side effects include sedation, increased falls, cognitive decline, metabolic effects, and QTC prolongation. When looking at QTC prolongation, quetiapine has a fairly high risk, followed by risperidone, olanzapine, and haloperidol. First-generation antipsychotics are more likely to lower seizure threshold, while second generations are safer. Number needed to harm is highest for Haldol, followed by risperidone, olanzapine, quetiapine, and aripiprazole. Health Canada says there's a 1.6-fold increase in mortality related to heart failure, sudden death, or pneumonia, and 1 extra stroke or death for every 100 people treated. A quick word about dementia with Lewy bodies. Remember to avoid first-generation antipsychotics and, to a lesser extent, your atypicals, as they can worsen Parkinsonism, cause decreased LOC for up to a day or two, and precipitate neuroleptic malignant syndrome.
Haldol really only should be used in emergent situations. Its efficacy is equivalent to olanzapine. For the second generations, brexpiprazole was just approved in the US in June of this year for managing agitation, but is not yet approved in Canada. There are some questions around efficacy given the studies that were used to get drug approval. Aripiprazole shows modest effect on agitation, similar to risperidone, but with a better side effect profile. Risperidone has been approved for AD-related aggression and psychotic symptoms in Canada and for BPSD treatment in Australia, New Zealand, and the UK. Health Canada specifically says risperidone is only for short-term symptomatic management of aggression or psychotic symptoms in severe AD unresponsive to non-pharmacological approaches, and when there is a risk of harm to self or others. It's less sedating than quetiapine or olanzapine, but it can still cause orthostatic hypotension and falls. There's also an increased EPS risk. Quetiapine is often used because of its good tolerability, but doesn't actually show good benefit, even in Lewy body dementia. Pimavanserin is a newer second-generation antipsychotic currently only licensed in the US for Parkinson's disease dementia-associated hallucinations and delusions.
At the end of the day, remember to treat the urgency of the situation and consider risk-benefit ratio, especially for antipsychotics. Make sure to involve the family in the prescribing discussion given the inherent risks associated with antipsychotics. And if they're not needed, put on your deprescribing hat and get rid of them. If this episode was helpful, pass it on to your colleagues. Thanks to our peer reviewer, Dr. Weins. Opinions expressed are our own and don't represent any affiliated organizations or institutions.